14-year-old woman, history of neurofibromatosis 1, 7 centimeter well circumscribed extradural mass. Tumor has neurofibromatous look, very cellular. Once we go deep into the tumor, we can see a fascicular pattern, hypercellular, almost attempting to do like a herringbone architecture with easy to find mitosis. I found 3 mitosis per 10 high power field and these areas of heterotopic ossification. S100, entirely negative in fascicular areas. Same thing, SOX10, completely negative in fascicular areas. Other negative immunostains, STAT6, EMA, GFFP, and Ki67 was 10%. We can rule out solitary fibrous tumor, STAT6 is negative, glial tumor, GFFP negative, EMA negative meningioma, and S100 negative for melanoma, and the morphology is not good for any of these tumors. We can rule out neurofibroma, yes, it's hypercellular, the fascicular architecture is not good for neurofibroma, the mitosis are not good. Remember, neurofibroma, plexiform neurofibroma evolves to malignant peripheral nerve sheath tumor, not schwannomas, and generally plexiform neurofibromas are more common in neurofibromatosis 1. Schwannomas are more common in neurofibromatosis 2. We know that this is not a schwannoma. The architecture is not good, no Anthony A, no Anthony B, and we don't have the diffuse S100 positivity of schwannoma. And the most important differential here is we know that it's not a high-grade malignant peripheral nerve sheath tumor. This is a tumor that is bluish, hypercellular, fascicular, herringbone with easy to find mitosis, and there is geographic necrosis. So the diagnosis is AUNP or low-grade malignant peripheral nerve sheath tumor. AUNP is atypical neurofibromatosis neoplasia, uncertain biological potential. The differential with low-grade malignant peripheral nerve sheath tumor is very well explained in this article from Human Pathology. Criteria for AUNP, atypia, loss of neurofibroma architecture. The third one is hypercellularity, high cellularity. And the fourth is mitosis. We need more than 1 in 50 per high power field and less than 3 per 10 high power fields. We need 2 out of these 4 criteria. Some features favoring AUNP or low-grade malignant peripheral nerve sheath tumor over neurofibroma: reduced or absent SOX10 or S100, reduced CD34 fibroelastic network, Ki67 more than 5%. Most neurofibromas are less than 5%. AUNP or low-grade, they are more than 5%. Loss of P16, neurofibromas are P16 positive. The loss of P16 may be in favor of these entities. And the last one is high Ki67 proliferation, high P53. If you have 100% nuclear staining for P53, it's almost sure a malignant peripheral nerve sheath tumor. If it's only mildly increased, maybe one of these entities, AUNP or low-grade malignant peripheral nerve sheath tumor. 3 findings favoring low-grade malignant over AUNP: complete loss of H3K27M3 expression, only present in 50% of the tumors. Mitosis 3 to 9 per 10 high power field in non-necrotic tumors or heterologous osteocartilaginous differentiation. This is also possible in benign tumors, but more common in malignant. So is this an AUNP or low-grade malignant peripheral nerve sheath tumor? Not easy to know. Many people will call this AUNP, others will call this low-grade malignant peripheral nerve sheath tumor. It doesn't matter if the tumor is well circumscribed. A patient may be cured, and the recurrence or mitosis is probably low for these tumors. So the message here is clinical and radiologic correlation is very important in this diagnosis. The diagnosis between AUNP and low-grade malignant peripheral nerve sheath tumor is difficult. This is a histologic continuum, a gray zone with not a clear-cut differentiation and expert opinion may be recommended for these cases.